Okay, good morning. Thank you again for coming. Thank you, Dr. Gorman, for giving us the opportunity to present the Multimodality Imaging Conference. We have a great case that will be presented by our senior fellow, Stephanie, who will also be the advanced CT MRI fellow next year. And again, this case goes beyond the heart. Until now, we mostly talk about the heart, but this will be different, and I think will be great. We have also great panelists, Dr. Olin, Professor and Director of Vascular Medicine at Mount Sinai Heart. Thank you, Dr. Olin, for coming. Dr. Lin, Associate Professor of Cardiology and Imager, and thank you for coming and meeting you. And also Dr. Patel, Assistant Professor, Interventional Radiology, who will tell us about the intervention for the case. Thank you for coming, sir. Nice meeting you. And our moderator will be Dr. Hadley. And Stephanie, sorry.
Thank you. Alrighty, so good morning, everyone. Thank you so much for joining today. My name is Stephanie. I'll be presenting today's Multimodality Imaging Conference. And I just wanted to thank our panelists again for being here today. So I'll get started. So this is a 25-year-old female who presents to clinic for the evaluation of hypertension. This is a new diagnosis of hypertension diagnosed several months ago when her blood pressure was consistently greater than 150/90s. She says that she's generally been feeling unwell with weakness, fatigue, and head fogginess for the last couple of months, but otherwise no chest pain, trouble breathing, stroke-like symptoms, arm or leg claudication, or syncope. She does endorse or report this remote history of systemic illness about 3 years ago. The etiology is still unclear, but it lasted a couple of months with fevers, night sweats, and migratory rashes. The ESR and CRP levels were unknown during this time, and it eventually just resolved on its own. So her past medical history is only notable for this new diagnosis of hypertension. Her medications include amlodipine 10, bisoprolol 5, and sertraline 50. She's not allergic to any medications. Her family history is notable for rheumatoid arthritis and lupus. Her brother had a VSD and an aortic coarctation repair as an infant, and she has no history of aneurysm, dissection, vasculitis, or peripheral vascular disease. For social history, she's a non-smoker, denies any drug use. She works as a homemaker, and she has 2 children. So these were her vitals during the clinic visit. Her heart rate was 90. For her blood pressure, her left arm was 92/68, and her right arm was 115/67. Her physical exam is otherwise notable for a left supraclavicular bruit. She had normal heart and lung exam, and for her extremities, she had a left radial pulse that was not palpable. Sorry. She does not have any EKG or chest x-ray in our system. But now I just wanted to ask the audience, what is your differential diagnosis at this point? This is a 25-year-old woman with a new diagnosis of hypertension. On physical exam, she had a discrepancy in her arm blood pressures, left supraclavicular bruit, as well as left radial pulse that was not palpable. Voice answers.
Can you put up the QR code one more time? You should be able to just look at the QR code there on the slide, and it'll take you to the poll everywhere. Thanks.
Sorry, give away some answers. Awesome. I think this is a pretty good spread of differential diagnosis. Dr. Olin, what were you thinking when you met her in your clinic based off of her clinical history and her physical exam? Is there anything else that you wanted to add or you were considering when you met her?
No, I thought I knew what was going on, so there was nothing additional that I was thinking of.
So explain to the fellows what they should be thinking.
Well, first of all, I tell every fellow that during the first time you see any patient, you should take the blood pressure in both arms. Hardly anybody does that. And when you have the onset of hypertension, secondary, hypertension in such a young woman, you would think of things like fibromuscular dysplasia, but the absent radial pulse and the supraclavicular bruit tells you she probably has either subclavian artery stenosis or occlusion. So you put those two together and it equals a inflammatory vascular disease, and in this age group, it would be Takayasu's arteritis.
Thank you. Okay. So she does bring some outside hospital imaging with her prior to Dr. Olin, her visit with Dr. Olin. Dr. Lin, would you be able to walk us through the CTA images? I'll just have it
by
play.
itself?
Yeah.
This is my.
Oh, thank you. All right, so the slices seem to start below the left main. So we're mostly looking at the aorta here, and then you start to see these very large ectatic vessels. There's the celiac, it's really dilated, and then you see there's renal artery stenosis right there. And there looks like there's a parallel aorta almost through collaterals, and then now it reconnects back to the IVC through the inferior mesenteric. If we can go back up, then we can focus maybe more on the aorta itself. And a couple of features is we're going to start to see this narrowing of the aorta right there, right below the dilation. And then you also see this kind of wall thickening. Go a little further. Yeah. You can see that while it's getting stenotic, the wall is also thickening. There's supposed to be a sign of Takayasu arteritis that, you know, I've not personally seen before, which is supposed to be like a double ring enhancement, like a napkin ring sign on the outside of the aorta. But I think maybe we're not at the right kind of contrast and to see it.
Also not gated, so it makes the wall.
They're not gated, yeah.
So I think it's an acute Takayasu's, right? Like,
Yeah, it's supposed to be more acute. I've not seen it myself.
And Dr. Fusa, just to kind of sum up where we are at this point, this is a 25-year-old female with new diagnosis of hypertension, and she's undergoing evaluation with Dr. Olin. On exam, she had discrepancy in her arm blood pressures, bruit, and left radial pulse was not palpable.
If I could make a comment about this.
Yeah.
First of all, they should have started much higher up. But in this case, she not only has renal artery disease, severe on the left, but she has long, smooth narrowing of the infrarenal aorta, which is a type of Takayasu's that predominantly occurs in people from India or South America, but you can get it in anyone.
So I just have a couple other views from the CTA. Dr. Lin, would you be able to walk us through these?
So here on the, we're really, on the right, we're really able to see that kind of double aorta and the collaterals much better. And then I think the other thing you also kind of notice is in the coronals, that there the renal artery stenosis is much easier to see.
Thank you. Next, she also brings an MRA with her, and there are several different images, views for this, but I thought this one highlighted the significant vascular findings pretty nicely. Dr. Lin,
So you can see really nicely there this left subclavian stenosis, and then that kind of string of beads appearance that's supposed to be very typical for Takayasu. And then in this, also here, the connection of the infrarenal aorta seems to be much more thready. So I wonder if perhaps it's like at a higher spatial resolution than the other images that we were seeing, because it did not look this stenotic in the other images.
Any decrease in pulses on the lower extremities?
no, the pulses were normal in her legs.
Can you just put the cursor on those stenosis for the audience? Left subclavian's there, and then the infrarenal aorta.
Perfect. Thank you, Dr. Lin.
So one thing to note is atherosclerosis does not occur distal to the takeoff of the vertebral artery. So if you see narrowing of the subclavian distal to that, it's some other disease. Takayasu's, giant cell, radiation arteritis, it could be a number of things.
Thank you. So she is referred to room at this point, and she has a lot of blood work done. Her inflammatory markers during the rheumatology visit was elevated with an ESR of 35 and a CRP of 6.6. And you can see she brought prior laboratory work with her, and about a month ago, her inflammatory markers were normal. She is now anemic with a hemoglobin of 10.7 when previously it was 13.4, and she does have a normal creatinine at 0.54. And now she has a mild leukocytosis with white count of 12.1. Otherwise, her rheumatologic workup was unremarkable, except for a positive lupus anticoagulant, which is deemed to be irrelevant to the case. She does have a negative Hep B, Hep C, and TB, and she started on aspirin. So now I want to take the time to ask everyone, what would you do next? Would you just continue medical management since her blood pressure is seemingly well controlled on the 2 agents she's on right now? Would you refer her for revascularization because of her severe stenosis in the renal artery? Would you get more imaging with vascular ultrasounds, MRAs, or PET? And there is not, one correct answer for this. How do I go? Dr. Olin, do you have any thoughts on what you would do next for her?
I forget exactly what I did, but I'm sure I got an ultrasound. And the reason being, I wanted to make sure that the right side was normal, and it gives you an idea of, how severe this is. Plus, if you're going to do an intervention, it gives you a pre-intervention ultrasound so you can then follow the patient. I'm not a big PET scan in this because the specificity of it is so poor. The sensitivity is pretty good. And anything you do, you're going to do medical management. But you don't want to do a procedure during the active phases of this disease unless you have to. For example, if you had a left main and they had an acute coronary syndrome, you have to do a procedure. But otherwise, you treat them medically, you cool them off, and then you refer for renal artery stenting.
Dr. Owen, what kind of information is a vascular ultrasound going to give beyond the CT images we already have?
Well, it's going to give you, first of all, that first CT that I saw was so grainy I couldn't tell what was going on. So it would give you an idea of whether or not there's a severe stenosis there. It would also, you would get a good non-invasive way of looking at the size of the kidneys. And you can also insonate the aorta, and you'll see that I think the aorta had velocities in it infrarenal above 400. So that tells you the stenosis is much more severe than you think that it may be.
Jeff, can I ask you a question? There is an evolving interest on the thoracic aorta. I'm talking about aneurysms and so forth with the use of PET. And actually, there's a lot of data coming up that when you have a dilated aorta and you don't know what is going on, better you do a PET to see if there is activity for vasculitis. This is I'm only talking about the thoracic aorta. You don't think it would be appropriate to do it, because it's academic, I would say, to really get more and more information about activity of disease, even in diseases like this?
I think it might be important after you treat the patient initially, because then inflammatory markers are not accurate, but to see if there's a recurrence of disease. But we have, even in JACC, we've published cases where it lights up on PET, but it's not really active disease. So I don't know, a lot of people do it. The rheumatologist who is involved in this case does like PET scanning. The other thing I'd like to point out, can you go back to the MR for a minute? Okay, look at that subclavian artery. We would never attempt to intervene on that, but Dr. Fuster and I reviewed a paper for JACC where a group in India would say, intervene, intervene, intervene. Keep intervening until you get it right on any blood vessel. And they would have intervened on something like that. Remember that paper from?
Jeff, can you discuss a little bit about the hypertension, the renal artery stenosis? This woman's just on 2 medications, pretty well controlled. She does have the differential, but her pressure is controlled despite the severe renal artery stenosis.
Yeah, she'll lose the kidney if we don't do anything. She'll lose the left kidney for sure, and I forget what the right kidney showed. But it's not uncommon to make this diagnosis when you see a discrepancy in kidney size.
Thank you. Just fast forward. Okay, so like Dr. Olin said, she does get some carotid or duplex ultrasounds, and I'll start with the carotids first. Dr. Olin.
What are you doing? We went over this.
Okay, so this is looking at the right common carotid artery, and you can see here there's some circumferential wall thickening, and you can see it nicely on this view, and this just highlights the thickness. And looking at the velocities through the right common carotid artery, it's normal velocities in the systolic and diastolic here.
So the important thing there is diffuse thickening rather than focal, correct?
Yeah, it's circumferential, but that's not even that impressive for most Takayasus.
This is now looking at the left common carotid. You can see here maybe a little bit of the circumferential wall thickening again, but on this view you can see it more pronounced. Now highlighting the left subclavian, the left axillary artery, which were concerning on the CTA and MRA. Once again, the circumferential wall thickening here. And this just highlights it a little bit more nicely. And now in these arteries, you can see that there's an elevated peak systolic velocity, 260 in the left subclavian and 163 in the axillary artery, suggesting there's severe stenosis in these arteries. Anything else to add, Dr. Olin?
Dr. Olin, once the disease is cooled off, do you expect to see less thickening?
In severe concentric wall thickening, no. It's fibrotic. In mild, well, actually, the left side here is pretty severe if you look at the axillary artery in the bottom middle one. You rarely see it regress.
Thank you. This is just the read for that. And this is now looking at the renal duplex ultrasounds. Dr. Olin, do you want me to go, or you want to go over it?
I'll take this. So if you look at the infrarenal aorta, top middle, you see a tremendous amount of turbulence to flow. You have to make sure your color velocity scale or PRF is set properly, which it is. And on the right, you can actually see the area of stenosis of the aorta. And yes, the velocities are close to 500 centimeters per second, which tells you this is a pretty severe stenosis. She did not have claudication, though, interestingly.
And then a couple more images from that duplex ultrasound.
Okay. Now, this is one of the reasons why you get a renal artery duplex. Yeah, the stenosis looks severe, but you have a peak systolic velocity of over 700 and an end diastolic velocity of 315. That is almost like a subtotal stenosis of the artery, and it tells you really need to fix that.
This is the read, just summarizing what Dr. Olin said.
So, Dr. Just one question. If her peak systolic velocity in the aorta, the ratio is still less than 2.5, right, or less than cutoff you want to use.
You mean the renal to aortic
Yeah.
ratio? We don't use it in a situation like this.
Okay.
And now we have some repeat CTA images. Dr. Lin, can you walk us through these?
So this looks like they're maybe maximum intensity projection images. So we're gonna have, it's gonna be great at seeing things that are kind of longitudinal in our axis, but not great at seeing things that are on end in our axis. So there's first we can say like the ascending aorta and the arch are fine. And then we are passing through the left main and the coronary arteries, but because it's a maximum intensity projection, it's actually, you can't like separate it from the PA, for example. And then now we're getting better definition, again, of the infrarenal aorta. We see these collaterals again. We can see they go through the hepatic and the splenic right there. And then, I'm sorry?
I'm sorry, I'm just asking if she could put the cursor
Oh,
on the screen
sorry.
for the audience, yeah.
Can
Sorry.
you go back to that renal artery?
Yes.
I want to see the right renal artery.
If you can stop so people can see what you're talking
Stop
about.
it right
so-
there. Can we say, either of you guys, can we say there's non-stenosis there?
Yes, she has the-
It doesn't look like it to me. On a MIP, it's always hard to rule out stenosis like this, especially when it's like in plane. But I mean, looking at, when I saw her images from the regular CAT scan, it looked okay. Especially not as severe as the left side.
If you come back up, I think a couple interesting things you see also are in the chest, when you go all the way up to like the superior part right there. So you can see that she has,
Point to where you say you can see, so people can see.
oh,
So
okay.
either, so she
There's a
has to use the
pointer?
pointer.
Oh, okay.
Or
If
if you go up and Dr. Lee, use the pointer.
Oh, okay.
Just so they can see what you-
I'm sorry, I'm not sure what
Yeah,
you're.
you can see, you can't see what you're saying.
Okay, all right. Here you can see that there are, and this is very unusual. Oh, whoops, I'm sorry. I don't know what I'm doing. It's very sensitive.
If you click, it'll just play to the next one.
Why can't I? Here.
It's just a video, so.
Jeff, is there any issue about using dye, contrast dye in a patient
Could you help me
that
point
leaves
over here?
stenosis?
So
Even
what
though
I'm-
creatinine's normal, considering that she has one kidney with a subtotal stenosis.
I need to go back up. She has collaterals in her breast that go to the subclavian. So you can see here on the upper right, there's collaterals right there. I don't know why it's not. Yeah, it won't stop there. But that's kind of also how you can see the chronicity of it, right? And also the,
Yeah.
right there, right? And then she has maybe a little one in the other side too, but not as prominent. I think the other thing that was interesting here, and again, I don't know if I'm gonna be able to get this to
I
work.
think now that it's stopped, it'll be better.
Okay, is, I mean, with Takayasu, there's also a variant that has pulmonary arterial involvement. And I mean, I don't know what her echo would have been, but you can see this branch here, it has some circumferential thickening, the way the carotid did.
Thank you. Okay, I have a couple more views from this CTA, Dr. Lin.
I think this is probably an ungated study, right? So it's not gonna be great for coronary evaluation, but you can see it. Here, we're also in maximum intensity projections. Looking for the left main, you're usually best off in like a coronal, and so it's very hard to say there because the PA kind of comes in right where the, but you can kind of see, there's a little silhouette of the left main that is like, that we're passing by, and then it never completely connects with the aortic root.
You show it.
See it best on the axial images.
Yeah, I think we did see the left main well on a different,
View.
yeah.
Also, it's okay to read the study in maximum intensity projection, that's how we read it, but the thickness of the slice that you increase when you're reading this is probably a really high thickness. So you're losing that, that resolution that you normally would see.
Onto these next sagittal and the candy cane view.
In this rotation, you can almost see the silhouette of the left main, and it never completely connects, but it's just not a great image for evaluating the left main. And then you can also see the RCA is very difficult to see with all of that contrast artifact in the RV.
So This is the read, and just like Dr. Lim was saying, there's a possible severe left main disease, but our patient does go on to get a coronary CT, which is completely normal, so I did not include that here. But at this point, you know, we have this young woman with elevated inflammatory markers. She has significant vascular findings on her CCA, and so given all of this together, it was deemed that she was most likely having an active Takayasu's episode. And so she started on prednisone to treat this active inflammation and to minimize arterial injury. And unfortunately, she does have some difficulty sleeping and some increase in anxiety with this medication, but overall her fatigue had improved. And her repeat.
What's the dose? Do you start off massive doses?
A
and
milligram per kilogram.
And what's the tapering, or how long do you keep it?
Well, you keep it at least for 4 to 6 weeks, and then you see if your inflammatory markers go down, and then you start to titrate. And if they recur, then you add a biologic of some type.
So do you re-image afterwards? Do you know how much of that is chronic and not going to go away, and how much of that disease will regress, or is it just to prevent progression?
Well, the subclavian is not going to regress, and the renal artery is not going to regress. And that's really the only two things you care about right here. And from this point forward, you study her to make sure she's not developing new vascular territory involvement. I always work with the rheumatologist on this, by the way. I think with this, I worked with Robert Spira, who's a world expert on large vessel vasculitis.
Dr. Olin, in addition to steroids, are there any biologics that you would initially
I
start?
think you're going to get to that, right?
Yeah. So yeah, on the prednisone, her inflammatory marker is normalized. And at this time, she's referred for revascularization, since Dr. Olin said you would only want to revascularize when the patient is no longer in active disease state, since it does increase the risk for complications like restenosis. And so this is her angiogram. I have several slides on this, but Dr. Patel, would you be able to walk us through the angiogram and the interventional approach for her?
Yeah, so they went up the left groin. I'm not sure, I don't remember why. But anyway, so we usually do this with a 6 French guide cath. You can see this is an aortogram of the infrarenal aorta. You can see sort of the smooth tapering of the infrarenal aorta. And if you pause it, right there, you can see there's actually 2 renal arteries, which I don't know if you picked up the second small.
Of course we did.
So you can see sort of this more smooth narrowing. It's not really disease of the origin of the artery. It's sort of just beyond the origin of the artery. There's post-stenotic dilatation. The accessory artery also looks like it has some stenosis. The right one isn't so bad. There is some disease in the right side as well, but not nearly to the degree of the left side.
Well, one thing you do see is you see that the distal renal artery on the right is larger than the proximal renal
Correct.
artery, and that should not occur.
Right, yeah.
So either there's a stenosis proximally or ectasia distally.
So can I ask a question? As we in cardiology always have this debate. You have functional, which is the physiological. Jeff did the ultrasound, which at least physiologically the flow looked more significant than the degree of stenosis. So do you go by the flow, or do you go by the anatomy, or you synthesize both?
We do both. So for most of our renal interventions, obviously unless it's like an absolute pinhole kind of thing, we will always do FFR and IVUS in those cases. Yeah, and even for atherosclerotic disease, I think the data would suggest unless it looks like a pinhole, you should do pressure, at least a
How
little
would you
pressure.
describe this, if you were visualizing this, the degree of
It doesn't look, I mean, it looks bad, but it doesn't look so bad where I would skip the step, right? We would, yeah.
So I'm saying that his flow made
Yeah.
it appear a lot more significant.
Exactly. The ultrasound would have suggested it was much more significant.
I mean, that's pretty severe. You can't get much more severe than that.
It is bad, but it's not a pinhole, right? Like we didn't have to work to get the wire across or.
The infrarenal aorta is better than what we've seen before. Well, at least grossly to inexperienced eye.
Stop it there. You can see that long narrowing.
But it looked really ugly, and it doesn't look quite as ugly here. Either I'm being as misled.
Sorry, guys.
All right, I guess I shouldn't speak. They look disparate, and I wonder whether it's, I'm not understanding, or something's changed in terms of with the steroids. I'm just,
So, I mean, obviously this is more of a luminogram, right? So you're only
Yeah.
seeing the inside, so you don't really see the outside. If you look at the diameter of the infrarenal aorta just above
Yeah,
the
yeah.
renal, there's a significant difference in
but this doesn't look like it should generate 4 meters per second. I don't know, maybe
Yeah.
not.
That's why you need duplex.
yeah, it's way,
That's what
yeah.
I'm saying, but this picture doesn't look the same, and that's why I'm,
Yeah.
those don't fit together for me. Okay, let me not interrupt more, sorry.
Yeah.
So just a couple more.
So again, we do this with a guide, we usually use a no-touch technique, although we just skip those steps, but it's a 014 wire here, and you can see basically the two arteries that, we didn't do them this way, we treated one and then went to the next.
Treated one, and then Rob called me, said there's this little renal artery axillary, and he said, I can easily do it. And I said, just do it. And he put a drug-eluting stent in there, I believe.
I think we put drug-eluting stents in both. Not that there's data specifically to Takayasu, it's just more based on the size of the artery, and that's sort of our preference, is to put a drug-eluting stent.
And this is just,
What do you find with the vasculitis versus, sclerotic arteriosclerosis? Is there more likelihood of restenosis because of the inflammation, so you have to continue to suppress the inflammation?
Yeah, that's been our experience with this disease. There's not a lot of data for Takayasu's, they're not big series, there's like 30, 40 patients. There is technically a surgical intervention for this. Those tend to thrombose, and obviously, and it would be a pretty morbid procedure given the accessory renal artery. It would be difficult. You'd probably lose that artery during surgery.
What antithrombotic therapy do you use, and how long do you continue with?
So again, partly driven by the fact that she has a drug-eluting stent, we put dual antiplatelet therapy. Typically, at least 6 months, if not longer, for the dual antiplatelet therapy. I mean, she's going to be on aspirin, I think, for life. So, yeah.
Is there a risk of dissecting the artery here that's higher than atherosclerotic disease?
Yeah.
Like you might see with FMD, for example?
Yeah, it's not as bad as FMD, and again, obviously, the more acute the Takayasu is, the more likely you are to encounter that. People have tried to do just straight angioplasty for these in sort of the chronic phase. The thing is, I don't think she's really burnt out Takayasu's quite yet, so I would be a little bit leery of just trying to do angioplasty. And then if you do it here and you do angioplasty, you'll end up with a dissection, you end up having to extend the stent further than you probably would have liked to begin with.
As you mentioned, the FFR, what was it?
I don't remember.
I have it here.
Yeah, I think she has it, yeah.
It's 0.75 in the main, and then 0.82 in the left accessory. And afterwards, there's 1.01 and 1.0.
I think the right side was fairly normal.
Yeah, there's no pressure gradient
Yeah.
in the right side. I'm not sure if I don't think it's included in this summary. I don't know if we want to just go over these images. This is just the left again, and this is when they looked at the right and there was no pressure gradient.
How long is there ever an indication for aortic?
Check what is the natural history here.
The first question, is there ever an indication for an aortic stent? I've never seen that, and I follow maybe 25 people Takayasu's right now. The natural history is pretty good, actually. If you keep them immunosuppressed, and they have to be immunosuppressed for years, and then the natural history is good. So what we always do when we follow these patients is they come to me, we do some imaging, then they go to the rheumatologist, and based on the imaging, we talk and decide whether or not to keep them on the same dose, to start decreasing the dose, or we need to find another agent to better control the disease. And her disease remained controlled on what you're going to get to.
Okay, so she gets her 2 stents, And as Dr. Patel said, she's discharged on aspirin and Plavix. Now she's discharged on amlodipine 10 only instead of the bisoprolol, since her blood pressure is somewhat improved. And she's continued on the prednisone. Her inflammatory markers remain within normal limits. And now she started on Humira with the prednisone taper. And the reason for the Humira was because she was a young woman and she was trying to get pregnant at the time. And so the other immunosuppressants that are used in Takayasu, like methotrexate, Cellcept, and azathioprine, are a pregnancy category X or D, but Humira is the only one that's more category B. So this was the one that was chosen for her. And just quickly running through, Takayasu's. I know we talked a lot about this already, but this is a large vessel vasculitis that primarily affects the aorta and its main branches, but it can affect the coronary and pulmonary arteries. It is a systemic and chronic inflammatory disease, and the pathogenesis is poorly understood, but it is thought to be due to an autoimmune process. So the typical age onset is younger than 50 years, and this is in contrast to giant cell arteritis, which can typically present in later years. It predominantly affects women, whereas in giant cell, it tends to be more equal distribution at least. And the incidence is greatest in Asia, but has a worldwide distribution. So the disease process is essentially a granulomatous inflammation of the adventitia and media in the vascular wall. And it is this vascular inflammation that leads to wall thickening, fibrosis, and ultimately stenosis. But these patients can also have aneurysms and dissections.
Can I make a comment? Yeah. This is pathologically the same disease as giant cell arteritis, but they behave differently, and the immunosuppressant regimen is different. So you could also consider the use of Actemra, tocilizumab, in this disease, where it's the treatment of choice in giant cell. I didn't answer Dr. Fuster's question completely about the natural history. There are some patients who present to you with occlusion of all these arteries, but they have no active disease. They burned out on their own. And I follow a number of them. I don't know why some people do that and others get progressive vascular disease.
So the diagnosis of Takayasu is based largely on the clinical presentation with the age of presentation and the physical exam, as well as the vascular distribution on imaging. They can have elevated ESR and CRP levels, but this is pretty nonspecific. And biopsies are not done typically because of the inaccessibility of the affected tissue. So this is a proposed diagnostic criteria for Takayasu's, and I won't get into the details of it, but there are major criteria and minor criteria. And the presence of 2 major, or 1 major and 2 minor, or 4 minor criteria has essentially a sensitivity of 92.5% and a specificity of 95%. And our patient essentially hits a lot of these criteria with left mid-subclavian artery lesion. She had the pulselessness or the pulse differences in the limbs. She had elevated ESR, hypertension, and lesions in other vascular beds. So imaging evaluation, it's very important in Takayasu's, but it's also important to differentiate this from giant cell arteritis. And so in Takayasu, these patients can have stenosis that mainly affect the entire aorta and its main branches, versus giant cell, the stenosis is mostly limited to the aortic arch and the branch vessels. Aneurysms can occur in up to 32% in Takayasu's, and it can occur in multiple vascular beds. This is in contrast to giant cell, in which the aneurysm can occur in up to 10% of cases.
So you mentioned the cerebral vessels. You're not worried about those in this diffuse systemic disease?
It's interesting because temporal arteritis is really a giant cell arteritis, but confined to the temporal arteries. So no, when it presents like this, it rarely affects the vessels above, but we always image them just to make sure. The aneurysms that are most common are the ascending aorta, and they develop aortic regurgitation, the root expands. So they need surveillance for life to make sure you don't miss that.
And so, yeah, if large vessel vasculitis is suspected, you want to image the entire aorta and its main branches up to the iliac arteries. And some different findings can include the areas of wall thickening, which can suggest active disease, but not necessarily. that can show the stenosis or occlusion or aneurysms, as Dr. Olin was speaking about. And so, like Dr. Olin said, you want to monitor them for the rest of their life, essentially, and the assessment of active disease relies on clinical symptoms, inflammatory markers, and imaging. Unfortunately, it can be quite challenging to monitor because activity does not correlate well with the biomarkers, and there really is no reliable imaging method for detecting disease activity. But nonetheless, routine imaging is recommended since vascular changes in Takayasu's can occur when the disease is considered to be clinically quiescent. And the optimal interval between imaging studies is not well established, but the ranges vary depending on the provider from every 3 to 6 months or even longer. So going back to our patient, her blood pressure is monitored closely after her stent placement, but unfortunately she does go on to need losartan for additional antihypertensive, and she gets surveillance imaging every 3 months or so. And so I include 2 of her serial renal duplex ultrasounds here. This one is shortly after her renal stent placements. Dr. Olin, I was wondering if you can walk us through these.
We were imaging her every 3 months initially, but then she spreads out to every 6 months and every year. The image on the left, top left, you see a lot of turbulence at the origin of the renal artery where the stent is. You can see the image on the top right. It looks like you're sitting in the middle of the aorta, but you go from an aortic waveform on the right-hand side to a classical renal artery waveform there. It tells you you're at the origin. And the velocities are normal throughout the stent, so this looks very good.
Thank you. And then she has some more duplex ultrasounds done, and this is done several months after the stents.
And here we're looking at the accessory renal artery on the lower right, and that looks pretty good too.
What are your thoughts on these, Dr. Olin? These images?
Oh, I forgot about this. Yeah, she's got in-stent restenosis on this. How long after was this?
So the stents were placed in March, and this is now February of the next year, so
Okay,
11 months.
so yeah, she's got a velocity of 510, end-diastolic velocity of 230 something, and a lot of turbulence within that. So that's in-stent restenosis. I forget what her blood pressure was
Her
doing.
blood pressure, I'm sorry, her blood pressure, because you added losartan, so blood pressure was not well controlled at that point?
At the point I added losartan, it was.
For the inflammatory markers up when this happened?
Not during this time period, no.
And we don't really use that for recurrence of disease. Because let's say she came back with a SED rate of 50 and a CRP of 10, but no new vascular involvement. We would just watch that. We wouldn't treat the numbers. And this could be in-stent restenosis just because you get that anytime you put a stent in, or activity of disease. And we thought it was in-stent restenosis. Her disease was well controlled, we thought.
Okay, so these are a couple more images from that last duplex ultrasound.
Go to that lower left image. You see that classical concentric wall thickening that was talked about before.
What happened with the in-stent restenosis? Was significant?
I'll get to it. So yeah, she is essentially considered for a left renal artery stent or re-stent. However, she does get pregnant during this time, and fortunately, she doesn't have any complication from the renal artery in-stent restenosis, and she delivers a healthy baby. However, the next time she does follow with Dr. Olin, she has some insurance issues with getting access to Humira, so she was off of it for several months by the next time she represented. Now she's reporting left arm weakness and numbness with exercise and when doing chores like changing her linen, etc. So suggestive of left arm claudication. And so a CTA is ordered to monitor for disease progression. Dr. Lin, I have several views of this. Let's start with this one.
So we have this very, very atretic subclavian, and there's that ring-like
Sorry, I'm playing slowly, I'll fast forward it.
Let's see if we can see the in-stent restenosis. Oh, probably not, it's too thick.
Yeah, CT's not so great for picking up in-stent restenosis. And the criteria on ultrasound are not the same. So we combined our series from here and MGH, and we came up with new criteria for stent arteries, not just in this disease, but in any disease affecting the renal arteries. So we wouldn't use our normal criteria for diagnosing in-stent restenosis.
And this is coronal view. I'm not sure if there's more.
What's the criteria, Jeff, specifically?
I think we've covered.
You're going to cover that?
Yeah.
You mean
we've covered,
ultrasound
yeah.
criteria?
Yeah, when you say you got,
Okay, so normally, the ultrasound criteria would be a renal to aortic ratio greater than or equal to 3.5, a peak systolic velocity over 200, and turbulence to flow. In stented renal arteries, for the highest sensitivity, specificity, positive and negative predictive value, if you have a peak systolic less than 240, you do not have in-stent restenosis. If your peak systolic is above 300, you do. In between 241 and 299, you have to use what I call artistic interpretation. You know, you have to see if there's turbulence to flow and make a decision based on that.
where did you publish that?
We published that in, where did we publish that? Maybe in CCI.
I think you should publish it. You should bring it over. Yeah, because these issues have been, I learned so much about renal artery stenosis since I was a fellow at the beginning at Mayo Clinic. They would open every renal artery. Then it became complete skepticism. And now you are at this stage in which you are quantifying, and I think it's nice to have this open much more.
I forget where we published it.
How big was the size of the stent that you placed in the renal artery?
Sorry, say that again?
How many millimeters stent?
The top one I believe was a 3, maybe a 4, and the bottom was a 5. We'll overdilate the 5.
Nice sized stents.
Yeah.
So Dr. Olin, you don't think that we'll be able to read on CT in stent stenosis based on those size stents? We can on coronal images, you could read that, I mean, on axial images, you could read the coronary arteries with greater than 3.5 millimeters. So I'm just wondering.
I don't know. You can't get physiologic information for sure.
No, of course not, anatomy-wise.
It also depending on how they did the CTA, right? Like for this, their slices are probably a little too thick to.
Was that done here in our, in cardiology? CT?
Yeah.
So we could
I
be,
do have these images, which I didn't include initially, just trying to see the stents a little bit better. I'm not sure if that helps.
yeah, we'd have to make the thickness really like close to 0 and really have to window and level it so that you see inside the stent and all the blooming artifact from the stent struts go away. But with that size stent, I bet we could probably see some.
Okay, so at this time, her inflammatory markers are now elevated since she's been off of Humira for several months.
Was she on any background prednisone?
I'm sorry?
Was she on any prednisone or it was Humira?
No, she was just on Humira at that point, or off of it at that point. And she is restarted on Humira. Unfortunately, you know, her insurance still does not cover it, so her rheumatologist is providing some free samples for her, and that's how she's being managed. Her inflammatory markers do improve, but not completely normalize with elevated CRP at 1.2. Unfortunately, though, her symptoms have not progressed. Her blood pressure remained well controlled on the agent she was on. Her creatinine was stable, and surveillance imaging did not show further progression of disease. And so for now, Dr. Olin decided to defer fixing the ISR. And
That decision.
kidney size is the same.
I did.
Huh?
I did, really?
Yeah.
That's why I see her every 3 months.
Yeah.
What's your criteria going to be to dilating again?
Those velocities are really high. I feel uncomfortable watching this. I talked to Rob Lickstein, we decided to watch it for a while. If the kidney starts losing volume, definitely intervene. If her blood pressure becomes out of control, definitely intervene. Rahul, what would you, if you did re-intervene, what would you do? Would you put another stent inside the stent, a covered stent, or
Yeah.
another drug-eluting stent?
It's tough. So I don't think another drug-eluting stent, well, first of all, there's no data for what to do, but I don't know if putting another drug-eluting stent would really work. You end up with the stent sandwich, right? You just stent and stent and stent. We could try plasting it. Again, that doesn't work terribly well. And so a lot of times what we've gone to is just putting a covered stent inside, so a VBX.
I mean, another option could be a drug-coated balloon, a larger diameter.
Yeah, we could do a DCB. It's hard to get because it's such a short stent to get a DCB to be appropriate. Also, because her aorta is so narrow to get it to 6. The shortest 6 millimeter DCB we have is 40. So you have to get a 40 millimeter stent across, or a 40 millimeter balloon across that stent and the aorta to sit is a bit tricky.
I mean, you'd have to let a bit of the balloon.
Yeah, let the balloon hang out, right? And then it's hard to get it to fully inflate, and it becomes a bit tricky.
Deepak, what would you do?
I'd probably treat it. I don't think I'd just leave it alone and wait for the kidney to shrink further. I think I'd go ahead and, I wouldn't put more metal in there. I don't think that'll help unless it was an issue of insufficient radial strength to begin with. My feeling is it was probably disease activity. I know she was on the Humira for a while. Things were okay, but my gut feeling is still that that's what contributed more so than just run-of-the-mill restenosis. It could happen anyway. 5 millimeter drug-eluting stent, the restenosis risk should be, low single digits. So I think it probably is all true and related that it is her disease activity. So now that she's back on the Humira, hopefully staying on the Humira, I'd say go ahead and open it up with the balloon. And I'd probably just do a regular balloon. And if it happened again, then I probably would do the drug-coated balloon, realizing it will be tough to have a bunch just sticking out in the aorta, but I would still probably bite the bullet and do it then.
So became pregnancy.
Probably within the year, the coronary drug-coated balloons will be out too.
Right, then we
So
can- yeah.
then it might be easier to do either the 3.5 one, if that restenosis, or even the 5 millimeter one.
Can pregnancy exacerbate the disease? Pregnancy, can
Yeah.
pregnancy exacerbate the?
I don't know. I haven't taken care of a lot of pregnant women, but you do have to take them off all the drugs except for Humira. And the other ones, like methotrexate and all that, they don't work in this anyway. If it's active disease, why did the large renal artery restenose, but the small one didn't?
I think that could even be said about just regular restenosis. Why does it sometimes is it one artery, but in the same patient it's not another? I mean, part of it, I think, is just kind of bad luck, random factors we don't know about. Local hemodynamic factors, perhaps, hard to say. I don't know.
You might have already answered this, but after hearing Dr. Sharma's grand rounds last week, is there any role in doing just drug-coated balloons and not stenting?
Well, there hasn't been so far. You have to realize there aren't a lot of cases of this in the US, and most of the cases don't involve the renal artery. Most involve the thoracic aorta and the branches of that, so no one really knows.
Yeah, it might be an interesting approach for FMD, where we typically would balloon and not stent. But for a lesion that involves the ostium, as it appeared both ostium are involved, there tends to be a lot of elastic recoil, so I think you probably need the mechanical scaffolding of a stent to prevent restenosis. The balloon angioplasty only literature for atherosclerotic renal artery stenosis looks really bad, so the drug-coated balloon might help a little bit, but it's not going to really help with the elastic recall component. So my bet is you probably still need the metal.
Because you saw the catastrophic consequences of her stopping Humira, and you could predict that'll happen again because of her insurance, would you give her just sort of low-dose prednisone and a background therapy just to avoid this type of complication?
She hates prednisone, even low dose. They all want to get off of prednisone, so I leave it up to the rheumatologist on what they. I try not to get involved in the micromanagement of the immunosuppressants.
And that was the reason why she wasn't started on prednisone. She really disliked the side effects she had.
And she really did not want another intervention.
What about her brachial artery? It has symptoms and
Yeah, there's not much you can do unless you live in South Central India. There they go after it, but there's not much you can do. I put them on like an arm walking program, essentially a dumbbell, and repeatedly cause claudication, rest, cause it, and usually it's not a big problem.
Thank you, everyone. So just to summarize, Takayasu is a large vessel inflammatory vasculitis. These patients can present with asymptomatic disease and all the way to having significant impairment from vascular damage. You want to consider this diagnosis in young patients with signs and symptoms of arterial narrowing without traditional cardiovascular risk factors. And if you suspect this disease, you want to image the entire aorta and its branches all the way to the iliac arteries. Unfortunately, there is suboptimal monitoring of the disease activity and progression, but it is important to monitor them lifelong. And you want to treat to control the disease activity and preserve vascular competence. And this is just a nice central illustration that was taken from a recent JACC paper, just highlighting the different important components of patient care in these patients, going from early diagnosis, assessing their vascular damage, the lifelong surveillance that we talked extensively about, and then the different therapies that are available to them, the immunosuppressants and invasive therapies.
These are the authors who promulgate the thing of keep going interventionally until you get it right. I just want to say Stephanie put in an incredible amount of time with this and did a really great job.
Thank you, Dr. Ola.
Thanks so much to our panelists, thanks to Stephanie, and also in the spirit of this being truly system-wide, we had reading rooms from Morningside and West also joining us, so thanks to our system-wide audience. We'll see you at the next one in December.
thank you.
Very nice, Stephen. Thank you. Very nice.
Thanks, Stefan. Thanks.